Dear students, we will discuss a operative view or laparoscopic view, which will give the idea what exactly it is, and it's again very interesting, not uncommon. Maybe a differential diagnosis for condition like appendicitis, and they will ask as a short note, worksheet they will ask, Viva they will ask, MCQ they may ask. So just find out what this condition is. So look at that here, intestine is there. This is not appendix because it's from the small intestine, where the appendix from the ileocecal junction, so the cecal site. So you can look at that here. So this is a laparoscopic view of the Meckel's diverticulum. What is it? It is unobliterated part of the white yellow intestinal duct. So white yellow intestinal duct is from the proximal to the ileocecal junction from the terminal ileum. It is during development period connected to the umbilicus, and before childbirth it gets obliterated completely, but sometimes it will be retained as a congenital anomaly. If it retains as a small part towards the umbilical side, it becomes a sinus. It may form a small cavity in the pathway. It is called forms something like cyst, or if this band may be there, it may cause a band and obstruction or fist and obstruction. And sometimes it will towards the intestinal side, it may get retained with all three layers of the intestine. Then it is called as Meckel's diverticulum. So it is a white yellow intestinal duct anomaly. So there are so many anomalies like towards the umbilical side, in between all those things. So you can always go through my manual of surgery for detail of this anomalies of the white yellow intestinal duct, which is often asked as a MCQ question. So towards the intestinal side, if it is retained with all three layers, it is called as Meckel's diverticulum. So often mimics appendicitis, that is the important thing. And remember, 2% common, 2 feet from the ileocecal wall, 2-inch length, or 2. This is easy to remember. 2% will be asymptomatic. The most common congenital anomaly of small intestine. Remember, it is arised from the antemesenteric borders. Look at that antemesenteric border here with independent blood supply, and which is 20% contain heterotropic epithelium. So gastric is the common again. Gastric is a common, that is the MCQ question. Commonest heterotropic epithelium present in the Meckel's diverticulum is gastric, duodenal, colonic, esophageal, like that. MCQ will be there. Gastric, remember, that's the right answer. You have to remember. Technician 99 is a diagnostic. Usually they are asymptomatic, but may cause bleeding, inflammation. Meckel diverticulitis, when it happens, mimics exactly like appendicitis. So miss for appendicitis. That's why during olden days, in open appendicectomy, once you do the appendicectomy, always pull out the terminal ileum, see there is no Meckel's diverticulum. That is the usual standard teaching. But currently, laparoscopic is the standard ideal approach. So in laparoscopy, always you can see the Meckel's diverticulum because the entire abdomen is visualized and assessed. So terminal ileum should be brought out and seen. That's the traditional dictum in olden days. When you do open appendicectomy through McBurney's incision or McBurney's approach. And intussusception can occur, bleeding can occur with the inflammation. Heterotropic epithelium due to there, it may form ulceration. So treatment is laparoscopy and proceed, Meckel's diverticulectomy and resection and anastomosis. There is the simple treatment. So this is the operative finding. You can see that typical Meckel's diverticulum, small bowel is there, Meckel's diverticulum. See that small bowel, how exact it looks, exact. All layers are there, even fat is there. So it got independent blood supply here. So this is the typical look of that. So for detail about the Meckel's diverticulum, it's a problem, so its presentations, its surgical approach with illustrations, please go through my SRB's manual of surgery, small intestine chapter. Current edition gives everything about the Meckel's diverticulum. And clinical methods in surgery, it gives a differential diagnosis. It also briefly it is given. Also, I request students, please subscribe my YouTube channel, which gives which will show daily lectures, briefly 8 to 10 minutes about different aspects of surgical images, case scenarios, specimens, operative procedure, suturing technique, and at regular intervals, maybe weekly or once in 2 weeks, live sessions about the case studies where students will present, and myself and different faculties will be there, senior faculties, for interaction and discussions like in exam. So that will give a lot of confidence to the students, and you can understand how exactly it is clinical assessment can be done and approach to a patient as a clinician. So answer the MCQ. If you answer, put it in the comment. I will acknowledge your answer. Gary's structure is A, B, C, D. Write the correct answer, and and I'll put the right answer later. And minimum small bowel length required to be retained is 1.2 meter, 2 meter, 2.4 meter, 2.8 meters. Again, put the right answer. It is a commonly asked MC question, NEET and other exams. And quotation of the day is all big things come from the small beginnings. So whatever you start, initially you have to think, start doing small things, then eventually widen it and becomes a big event. So that is anywhere, even surgery, small surgery you do, then eventually little more, then bigger surgery, then major surgery. It is not straight away you start doing major surgery, it's not possible. Skill gradually, progressively you have to attain, not immediate one day. It's not like a one day match, it's like a test match. Students, please go through my SRB's Manual of Surgery, SRB's Clinical Methods in Surgery, and SRB's Operative Surgery, Surgical Atlas. The new edition has come, and Atlas of Steering Technique. Manual gives everything in detail about all topics as per CBM syllabus: general surgery, gastrosurgery, urology, neurosurgery, cardiothoracic, and basic instruments, specimens, brief operative surgery, which is essential for UGs. Everything is covered with the quotations, with the illustrations, the diagrams, photos, covered everything as for CBM syllabus. And clinical methods in surgery, current edition gives a proper clinical idea, approaches to all cases, briefly orthopedic also. Again, it contains instruments, specimen, images also, and videos. Each chapter videos are there, how to examine a patient, which is very important when you do a practical exam, clinical exam. So very, very useful, everything, with again, lot of photos and proper methodology of examination with the differential diagnosis tables are given. So it will be very, very useful. Of course, operative surgery is a very detailed, 2-volume extensive book with more than 10,000 photos and illustrations. Whenever you want to, any surgery, including specialty, general surgeries, gastrosurgery mainly, in detail it is given. It will be very, very useful. So students, also go through my SRB's Surgery Insight YouTube insights, and please subscribe for all these lectures, daily lectures for brief 6 to 10 minutes, and live sessions once a week or once in 2 weeks I am doing. They're also very, very useful for students with with the interaction with the senior faculties are there, and always they can answer your doubts and through chat. So please subscribe my channel, YouTube, Instagram to have a better knowledge and increase your surgical knowledge as such, because it is free also. And my DigiNow lectures through JP, around 220 lectures covering everything surgery, including specialty, operative surgery, clinical methods also, with the videos through JP Publishers. And you can always purchase that one for 1 year, so that you can have go through all lectures, so have a very clear idea about the subject to face any exam, including NEET or final year exam or even PG exams. So students, I hope you understood this lecture very well. Thank you so much.